Welcome everybody to this 20th webinar organized by ECDC and the European AIDS Clinical Society. Before I let the other two co-hosts introduce themselves, I just want to say that we're going to try and record this one. A lot of people have asked for us to record it, so that's why we moved to this new platform on WebEx. So we'll see if that works well. The plan is to send the recording on the situation in Africa. So over to you, in case.
Hello, can you hear me?
Yeah, we hear you now. Please share your screen again, in case.
Let me do that.
Yeah.
Okay, can you see my screen over there?
We can, if you can. There we go. Perfect.
Well, okay, thanks so much for inviting the Africa CDC to provide really updates on the continental mpox response. We're very glad and pleased to be here. So I'm going to go through, I have 15 minutes. I'm sure the Q&A session will address some of the questions that we have not probably captured yet. So I think you all know the Africa CDC took a bold step. This is the first one to actually declare a public health emergency of continental security. I think, and then that was followed by the WHO on the 14th of August 2024. So I think you all know the phylogenetics, the clustering of mpox 2 clades and 4 subtypes, clade 1A, clade 1B, clade 2A, clade 2B. I'm saying that because we're going to probably touch a little bit on that in terms of what is available, current available data. But again, there's a lot here to learn, and there's a lot here to do in terms of research. We don't have enough really evidence to be able to drive any meaningful conclusion. As we say, we're dealing here with a disease which was classified a couple of years ago, if not months, as a neglected tropical disease. So what we know, the high-risk groups, now I'm giving this presentation from the DRC, the information we all at least have from the field. We have sex workers, men who have sex with men, healthcare workers, are immunosuppressed. I'm sure Prof. Abdul Karim touched base on that, particularly for South Africa, where we have that co-infection and post-HIV. I think currently limited access to countermeasures, and at least we also know data from the DRC on tecovirimat was not actually successful, at least for the African population. So what do we have? Currently, we have 14 African Union member states. The last addition was yesterday, where we have a new country that actually reported a case of mpox. So we have 5 regions on the continent: the Central Africa region, the Eastern Africa region, Southern Africa region, Western Africa region, and the Northern Africa. You start from there. The Northern Africa region, they have not reported any case of mpox. So the 4 regions primarily driven by the Central Africa region, with the DRC representing more than 95% of cases. What is very interesting here is that we've started seeing mpox being imported in countries that never reported cases of mpox in the past. So the map on the left that gives you a little bit of flavor in terms of the number of reported cases, and you can clearly see those countries neighbor to the DRC, all of them actually experiencing or have reported or affected or reported cases of mpox. But traditionally, that's exactly where the epicenter of mpox is, and we've kind of spread across 2 regions, the Central and the West Africa region. So this pictorial representation gives you a little bit, again, a glimpse on how the trends of really mpox in Africa from 2022. So the green one gives you a little bit the picture in 2022, and also gives you an idea of how that the number of cases are increasing over time. I think this is there's a lot of question around this, and we can all brainstorm. And people will argue around climate change. People will argue around more surveillance, with sentence surveillance, cross-border surveillance, and country surveillance. That probably we're getting more cases. But again, I think that's something we can discuss. The yellow one gives you a little bit what we had last year. So from 8,276 cases in 2022 to at least close to 15,000 cases in 2023. And in 2024, you can see that steeper increase in June. I think we took, we actually intervened as Africa CDC, as a public health agency, in April, because you see a small peak there in April, March, April. We had a high-level ministerial meeting when we saw this peak in the DRC, where more than 10 African Union ministers of health actually were brought together to start discussing our response and strategy with the increase of number of cases. So the most important thing here, that on this slide, we all agree there's a steeper increase number of cases from 2022 to 2024. And more importantly, the green one there, the right up there, we're not testing enough. So the question, do we really have an idea of the magnitude of the problem at hand? So if you're only testing 18 and we're close to 50% positivity rate, it means that we have more cases than actually we're reporting. I think that's probably the 2 messages from this slide: the increase over time from the trend analysis, really raw trend analysis, and also the testing rate. So if you look a bit monthly really trends as well, from January 2024, to the end of the month, August 2024. So you can see also that there's an increase over time. But again, you can look at it, August, we declare this as a public health emergency of continental security in August. Our understanding is that country actually reinforced their surveillance system, the robust surveillance system can be linked to the spike in number of cases in our member state and due to this reporting. But primarily what we're observing is that drivers are actually also contributing, the drivers cross-border transmission of this transmission in Africa. So the long distance of truck drivers moving from the Central Africa corridor to Mombasa. I think if they move the virus across those borders, there's likelihood of spillover to other members. The trade, and as I've said, is a huge corridor for trade. Healthcare seeking, usually people get tested or seek for healthcare when they actually have developed already some of these symptoms. Sexual transmission, we mentioned it, interaction with wildlife, as people actually in the rural or remote areas are really can be affected through zoonotic transmission. So basically, that's what we're seeing, at least for the past 8 months. So the DRC, I think where I am currently as part of Africa's CDC response or continental response, last week, new suspected cases, 1,095 confirmed, 1,838, unfortunately, 35 deaths just for last week. Again, here, among the confirmed cases, more than 40% are male, and children less than 10 years, 35%. I really want to have a stop on children to say we can again, there's a lot of unknowns here. The first point, looking at data on malnutrition, DRC contribute at least 42% of children are malnourished in that region, compared to Burundi, for example, 54%. Secondly, you all recall smallpox. We, all of you, or probably as me, I got actually vaccinated, inoculated the smallpox vaccines those days. So it was declared over in 1980. Now it's suggesting that those born after 1972, probably those children that we're seeing now high rate of infections, have not received any vaccines. I think they are more likely to have been exposed. Really, the immune system is not likely to have responded like those that have probably been exposed before. The adaptive immunity as well as probably that natural immunity, probably due to the exposure, previous exposure as well. So that's one. And then the third one, as we've said, among children, again, you can see we cannot really conclude that much there because we're still looking at the large database to be able to drive or probably have a meaningful conclusion here. The clade 1A and clade 1B, the risk factors, as I mentioned, I think, again, on safe sex practices and malnutrition, low vaccination coverage, population mobility. Again, that's a particularity of the DRC, the conflict in the East region. I'm sure Professor Jane Nachiga will also touch base on that. The interaction with wildlife, as I mentioned, and viral mutation. But again, viral mutation, we don't expect that much to be that driving factor. Again, we're talking of probably 100 or 500 sequences available. We need more information, cell culture and other informations, so that we can drive probably we can conclude or probably have meaningful conclusion on that. But again, the left panel there, you can see the overall weekly trends in the DRC and the number of confirmed cases and deaths that I mentioned. Overall, over 600, unfortunately, over 600 deaths in the DRC alone. So now, for those that are wondering, the clade, I'm sure most of you here are phylogenetists or geneticists. I just thought I would bring this very simple, really map and a simple phylogenetic tree on the left. Those are the two clade 1 and 2. The difference are linked to the differences in nucleotide or bases along the genome, and each of those branches will represent those clades, and the trunk is that little branch you see So the difference definitely provide the two groupings based on the homology similarity. And among the clade 1, you have clade 1A and clade 1B. And you see the map there and the countries where they actually be circulating over time. And then the clade 2 is like a branch of another, from the trunk, another branch. And this is actually representing clade 2A and clade 2B. So primarily, only Cameroon has clade 1A, clade 1 and clade 2. Those are co-circulating in Cameroon. And then you can see that clade 2 in West Africa and clade 1 in Central Africa in general and East Africa. So I think this is where we start looking. But again, as I've said, compared to HIV, we have over 9 subtypes, over 100 recombinants, over 100 unique recombinants. I think this virus doesn't mutate quite fast like HIV, for example. I think you understand that it's a little bit more slowly replicating virus. But again, we need more information here. So let's move now. How do we deal with the problem at hand? The Africa CDC and WHO, we actually came together to develop an integrated continental preparedness response plan, which is going to be released before the end of this week. And we're joining our effort together to be sure we respond efficiently to this outbreak. And the plan is to be able to continue on other outbreaks on the continent, cholera, dengue, and also I just want to be sure you're aware that we're dealing every single year with more than 160 events. So mpox is just one of those that pop up. Dengue is there. We have to deal with dengue. We have to deal with cholera. So I just want to be sure that you're aware that Africa CDC and the African Union, we deal every year with 160 at least events, including other that you know, which are endemic like HIV, malaria, and TB. So there's a global strategy and there's a continental strategy that we're working jointly with the WHO. So let me touch a bit base on the key components in that continental integrated strategic plan. There are some key principles. We have to have really align on partners around a single cohesive plan. One continental plan, meaning one budget, one M&E plan, one response plan. I think this is very important. So with limited resources, we can have really targeted intervention and be more efficient. So it's country-driven. Our intervention is evidence-based. When I say country-driven, the Africa CDC, we have 13 of the 14 country plans as part of the preparedness and response. So we're getting this plan from the country. We are co-creating the response because it's extremely complex to build a strategy from Geneva or from Brazzaville or from Addis Ababa. So we're getting this from the country. We then sit together, we co-create, and we provide the solutions together. And then that's going to be extremely important that you have the buy-in of the member state. So equity, focus, the vulnerable groups and those affected areas, a single collaboration mechanism, and then the sustainability is important. So the pillars of our response, coordination and leadership, risk communication, community engagement. You all know misinformation, disinformation can be really damaging for a response, particularly for pillars like vaccination, for example. Surveillance, cross-border surveillance, we need to reinforce genomic surveillance, the lab capacity, that's the most important, in my own views, as part of this response. We need to test, because if you don't have the drugs, the vaccines are pretty expensive. You need at least to test and be sure that those that are infected are being tracked within the community, and probably you can contain the virus. If you don't test, it means you're dealing with people that are moving around with the virus and they're spreading, making it difficult to stop the spread of the virus. So infection prevention control, case management, vaccination, logistic and operational support, continuity of essential services. We do not want to run into the same risk during COVID, where we all went into COVID response and other essential services. I think we're probably reprioritized. We really want to avoid that as we move in this response. And then the research and innovation, you all agree with me? There's a lot of questions, a lot of unknown, and then it's actually required that we actually really ask some very interesting, important questions, and then we address them as part of this outbreak. The implementation strategies, those I'm just going to probably zoom second to the bottom on ring vaccination. We are not doing mass campaign vaccination. No, that's not going to be a solution here. We're doing ring vaccination. At least where we have cases, the contact of those cases, we can find a better way to address that so as to ensure that, again, we respond efficiently due to limited access to countermeasures. But overall, it's not only vaccines. It's not only about therapeutics. Therapeutics, we don't have it. Vaccines, limited access, but it's also around diagnostics. So it's important that we also are cognizant that there's no rapid diagnostic for now, at least for those that we're dealing with. Molecular diagnostics, the advantage, we have the gene expert machines and that are portable point of care that we can leverage from the Global Fund program, from the PEPFAR program, and that we can put into use as part of this response. I think majorly, some of these countries are still operating under a very centralized system. What we're doing, we want to decentralize it, bring the test to the community, not the community to the test, because that's important. It's happening within the community. Then we have to bring those point of care machines to the community and get them tested. Optimize the platform in country, then to run and increase our testing 40% depending on the region, so that we can then, those hotspots, everyone suspected can be tested and either confirm or negative, and then we can provide appropriate case management. So diagnostics, therapeutics, vaccines are all in that same box around the countermeasures. So, but we're operating under the same principle I mentioned: unified approach, country-driven, evidence-based, equity-focused, and sustainability. We want to be sure when mpox is over, I'm sure that's going to be over, that we have a health resilient system to be able to already to prepare for any other outbreaks. As I mentioned, 160 every year. You don't want to build the system over and over, but again, you have to augment and elevate from where we have left. So we need to fast track research and development, develop manufacturing, platforms across the continent, strengthen our supply chains systems. So now on the vaccines, particularly, there have been donations, announcements across on the vaccines. We're making good progress there, thanks to the global community. It's very important. We've seen that global solidarity now in action. So the USA, we have about 10,000 doses from the US government that's been delivered to the donation to Nigeria. We have the European Commission, we're thankful, 99,100 doses will be delivered tomorrow to the government of DRC as part of the response and the donation for the European Commission, the Bavarian Nordic vaccines. We have 50,000 from the US government to the DRC, and 15,000 from the manufacturers, 100,000 announced from France, 100,000 from Germany. We need to confirm from Spain. We have heard two numbers, 100,000 and 500,000, but we are putting at least 100,000. Canada, 200,000 doses. I'm putting this number to say the list is long, and we're seeing that global solidarity. Thank you to our international partners. We need to see more of those really to support the African continent to be able to really respond to this outbreak. So in conclusion, this is my last slide. So if I summarize a little bit what we've been able to achieve, we actually deploy our team here, the DRC 24 staff from the senior management to epidemiologists 3 weeks ago. And this is what we've been achieved, and we've been working behind the scene and ensuring also that we support other member states, but the DRC is the epicenter. 95% of cases here, being here, we can actually support the government of DRC and also support our other member state, the 13 member states. So on the one continental incident management support team, 24-member team based in the DRC, the deployment of experts and the support from UNICEF, WHO sitting at the African Union office here in the DRC, the weekly coordination with the National Public Institute directors from the 14 affected member states. And the funding secured 10 million US dollar from the African Union. I'm going to tell you, this is the first ever fast tracking process within the African Union, releasing funds just even before the declaration. I think that's domestic resource mobilization. Then 10 million US dollar from the government of the DRC to support their response. We started really training the laboratorians and also epidemiologists from 7 member states on sample collection, diagnostics, and analysis. And also we're building, as I mentioned, that decentralized testing to be able to increase our testing rate. The mobilization of vaccines, I've mentioned already on that slide, with extensive support from our partners. We need more, but that's already a good signal. And lastly, the mpox research coordination. There was a meeting, a joint meeting, WHO, Africa CDC, CEPI, the US NIH. I think that was held on the 29th of August, and which brought more than 2,000 participants online, and as part of really brainstorming on research questions that can be added to the portfolio that the MREC consortium, led by Professor Jean Nachiga, that you have invited on this call, has been leading. I think this effort is already yielding some fruit, because we have been really ringing the bell for a couple of months now. I think that's taken off in terms of research coordination across the continent. So thank you so much for inviting us, and then over to you.
Excellent, PK. Excellent presentation. And before we get to the Q&A, can you make sure that you put on your video? We don't see you. I didn't want to stop you in midway through, but I don't see you at least. So if you can try again, that would be great. Really fantastic presentation, Nikes, and I see several questions coming in already. So if you don't mind, maybe we can start with the first one here. Jordi Casabona, who's asking, what is the profile of the deaths? Do you have information around that?
What is the profile? Sorry, I can't hear you. I didn't hear.
What's the profile of the deaths so far?
The profile of the death. So I think that's a very important, interesting question. If there's a profile of the death, I think the mortality surveillance team is now working closely with the government of the DRC and also the affected member state to be able to, at some point, do some post-mortem. For now, I think I'm going to just say we're going to provide that information next time, so that we get more accurate information on those profiles. But again, that's a weakness again in our surveillance system. Mortality surveillance is not usually as accurate as we'll have definitely expected. Thank you for the question.
Thank you so much. Thank you. Another question from Klaus, and please do raise your hands as well. It's nice to have some dynamic interaction here. Nikes, there's a question here from Klaus asking about the denominator of the testing rate, which says ranging between 12 and 18% in DRC. Was that all suspected cases? He's asking.
That's all suspected cases, correct? That's all suspected cases. We're using the WHO definition, and the suspected cases, the confirmed cases, and discarded. But again, as I've said, I think this is where we need really support again. It's and where we're supporting also our member state is to increase the testing rate and also the turnaround time, because if you are implementing a centralized mpox diagnostics, it means that sample moving, you know very well, for those who know, the DRC is a continent. Moving samples from North DRC to Kinshasa, I think that's going to take days, and you don't want to get that when the sample, they take days and get tested probably a couple of days after. That's not good, because we really have to test in real time. So the short answer, yes, it includes the suspected cases, all suspected cases, and then they confirm when they have the lab test as confirmed, they actually move from suspected to confirmed, and then we do adjust our denominator. Thank you. Back to you.
Perfect, perfect. We still can't see you, and I don't want to stress you, but it would be great to see you if you can. We have a question from Alex, and Alex, please put on your camera and ask the question.
Sure. Hi, Timur, and thanks for the great presentation. I sort of have two questions. There are two key populations that are vulnerable and particularly impacted by mpox, MSM and people living with HIV. And so I didn't really see, I was curious to learn more about how people living with HIV are impacted by this, as well as, for example, any sort of implementation strategy around vaccines. What plan is there in terms of ensuring that MSM have access to vaccines? We know it's sexually transmitted. We know that due to criminalization, it's very difficult to MSM to approach and ask for a vaccine or even expose themselves as having mpox symptoms. And it makes them particularly more vulnerable due to the legal situation. So what system is in place to ensure that that population can get access to vaccines, as well as ensure they have access to healthcare without facing stigma and criminalization?
Well, thanks so much for that very interesting question. I think you've seen the guiding principles, equity. We pay attention to that. And again, this is the African Union. We stand at protecting the 1.4 billion people on this continent, regardless of their sexual orientation. I think that's not a criteria on this continent as part of Africa CDC response. Everyone eligible as part of high-risk population deserve to have access to treatment, at least even the vaccines across the continent. It's not an exclusion criteria. I think we're going to be sure that we stick to that, and then I think we pay attention to that. So absolutely agree with you. The MSM, based on what we've learned from the 2022 pandemic, they are high risk. The HIV is a complication in this puzzle. I didn't mention it here, but for DRC, because we haven't disaggregated the data yet, but for South Africa, it's pretty clear. They have seen a few cases of mpox, the co-infection. So, and then we are using that case management developed in South Africa as part of building our continental case management for those that are co-infected. So rest reassured, there's no discrimination. Rest reassured that the African Union will pay attention to all eligible groups and all at risk of vulnerables for access to medical care. Thank you.
Thank you so much. We'll take one last question and then we move on. And Nikes has kindly agreed to stay on for the whole session. So depending on time at the end, we may address some of the more questions here in the chat. But Gus, over to you.
Yeah, apologies. It's really the same sort of question. Do you have any figures at all? And maybe not from immediately for the proportion of cases and deaths amongst who had HIV. I have seen figures quoted as high as 35%.
Hello, as I've said, if I heard you clearly, I think we're still looking to the line list and the data so that we can provide the accurate number. What you have currently is South Africa, which definitely, yes, is around that 35%. But for the rest of the continent, from those 18,000, we don't have that detailed information yet. But we do have according to at least cases by age categories, and at least even by social demographic and professional status. But again, we're going to come back to you next time. Hopefully, ECDC will invite us again when we have enough data, granular data to present to this group. So we will be more than happy to come and respond to those questions on HIV, co-infections, and also the frequency and proportion across the continent. Thank you.
Okay, thank you very much.
Thank you so much, Nikes. And you have a standing invitation, that's for sure. So please remain the case, and we'll get back to some questions towards the end. And I'll hand over now to Sanjay to introduce the next speaker. Thank you so much, Nikes.
Yes, thank you very much, in a case, and that was really fantastic. So from Africa CDC now onto the WHO. And so we're very honored to have Dr. Tran Nguyen, who's the Program Area Manager for Infectious Hazard Management at the Emergencies Program at the WHO European Office. The WHO recently convened an R&D blueprint meeting last week, end of last week, around mpox. And Dr. Nguyen is going to give us an update from the WHO. So thank you very much.
Thank you, Sanjay, and good afternoon, all colleagues online. My pleasure to join you this webinar series. And indeed, let me try to first of all, great that we have from Africa CDC and a brief update on situation in Europe. As you must be aware that after the first Clade 1 detection in Sweden, we are still on like watch mode, expecting if any other Clade 1 are imported in the European continent, but so far it's quiet still. And I was thinking that if not in numbers in Europe to present you here, I would like to initiate the opportunity to brief you a bit on our last Thursday, Friday, or last week we have a global research and innovation conference, and it was a two-day conference, and all these technical area was well covered in also a lot of technical detailed discussion. But let me try to summarize that conference for you. So if I can share my screen.
Let me know if you need help, Tran.
Oh,
Yeah.
somehow I cannot find the correct screen here on my tab. Whether do you have my presentation perhaps?
I do have it.
Yeah.
I'll share it now, Tran.
All right, so yeah, please, yeah.
Yeah.
So I close, all right, please. Yes, indeed. So on our two-day discussion, yeah, already the objective of that was is what I can call action for us to make sure that our all collaborative research initiatives that directly align and support the outbreak response goal. That's what WHO promote since West Africa Ebola outbreaks. As you know, the research response is really in our agenda. So all the major outbreaks. It's need to be collaborative, and the affected countries are on the driving seat, as well as bring all the partners to be contributing to that. So after this conference, we expect to have what we call research roadmap to facilitate collaboration and outline some skill step ahead of us. So next slide, please.
I'm trying here. Let's see if it's moving. There we go.
So on day one, mainly we spent some good time to discuss about epidemiology. We say that at the global level, mpox is stable, even decreasing, but of course in Africa it's increasing. And we touched about different clades, and we say that clade 1A primarily affects pediatric population and mostly driven by zoonotic transmission in DRC on the west part of that, while other clade 2 affects all age group, and our African continent, we have seen, as you must aware, that is transmitted through sexual contact. We describe it like two different outbreak almost, but say that clade 1 is a higher mortality rate. Nevertheless, it's not like a uniform picture. So clade 2 also, and particularly 2B, we mentioned about this Africa situation, the South Africa situation also. So it's really have a higher mortality, and particularly with among those HIV as mentioned. All in all, we see that it's a major knowledge gap remains in some of key epidemiological parameters, and most importantly, of course, the transmission route and also severity of the clinical picture. So the long session on vaccine, and we noticed that like Global already have noticed that the immediate challenge is the shortest of doses. So we need to prioritize other methods to extend the availability of vaccine, such that single fractional dose, intramuscular, intradermal. There's a randomized allocation approach, and we mentioned that's a ring vaccination already. So that could help to determine the most effective use of our limited doses in African continent altogether, and particularly in the context of HIV, malnutrition, other infections that make the picture really, and also the data challenging to obtain. On the diagnostic side, we don't have very good news as we know that at the moment what the urgent needs is the point of care PCR-based test that's need to have been more sensitive and more rapid diagnostic test is not really available. And also in some countries we do have Gene Express and some of these platforms, but again it needs to be scaled up. So it's really crucial to understand the transition dynamics and also improve diagnosis accuracy, as well, of course, case management. So diagnosis is really the key impeding factor now at the moment. Next slide, please. Yes, on the day 2, we spent talking a lot around therapeutics, and they are neither currently you must have heard about this NIH supported trial in DRC, what you call the PALM 007, which doesn't show that the tecovirimat is not reducing any length of lesion symptoms, and so meaning that in endemic setting, the tecovirimat may not be as the current evidence, so that is not that promising. So, you know, given that potential therapeutic to offer limited benefits only, so it's important for that what this was explained, something like factorial design in research, meaning that a combination of different factors and that can evaluate the effective treatments and also explore other aspects, particularly in the PALM 007, so that the supportive care already reduced the mortality compared with the general what we have seen, the 3-point-something% of mortality or case fatality. So in the trial, it's only reduced to 1.6, which is quite significant, and that is only thanks to the high-level standardized supportive care. We also discussed different session and also this panel discussion around what we call the community engagement, participatory different practices. And we reiterate say that we need to understand the community, the context, and engage the community preferably before crisis happen, to educate and also to share the concern, as well as prepare for engage them in the research effort, in the design, in the participant manner. So this would be like the way that we have more responsive and more compliances also in all the intervention, or the not only studies but also our response intervention. And we spend a lot of time also to highlight the importance of collaboration and coordination collaboration. So effective response requires really the collaboration not only across studies, but also different agencies, different regulatory bodies and players. So, and all acknowledge that we have better to have, of course, the well-coordinated study to have pooled the data, pool the results, instead of multiple studies that is side by side. Let me go to the next slide, please. Yes, so I summarize here some of the key takeaway of our two-day deliberation. So the first thing is that we acknowledge that, like our Professor Nikesh in the previous intervention already, that we need to address our knowledge gap and some of the key epi parameters, understand how the disease spread. The severity picture, we say that clade 1 is perhaps more severe, but it's not the case. If you now look at, for instance, all the case 1B, that is beyond DRC, that's is no fatality yet. Yeah, so that is really in the context of different variants to understand. And we acknowledge also that the clade 1B, the data is accumulating, but the data is very spare outside of the African context. So how the clade 1B that we are most concerned would behave in Europe and other part of other setting? That would be the critical question. So again, we need to have a better coordination among regulatory bodies, ethics committees, and also need to harmonize and standardize some of the protocol, whether it's on treatment, whether it's on other case management protocol. So that is highlighted multiple times. And we also recognize that now in GISAID, we can upload the mpox sequences, so establishing clear data sharing arrangement, frameworks, and platform. That is very critical for collaboration. Also, we mentioned again the important platform trial allowing to evaluate multiple interventions at the same time. And again, highlighting the importance of supportive care in clinical trials. This can address many critical questions about how to manage symptoms, secondary infections, and other case management related knowledge we need to accumulate. So about diagnosis tool, yeah, this the need of the hours really. We need to scale, and as mentioned, the point of care PCR-based tests need to have available, and it need to be adapted to the context now in Africa setting. And with regards to the diagnostic and the therapeutics, we say that it's really important to understand how to best use existing antiviral and treatment, and about the combination of therapies need to be taken into account in the next phase, definitely. Last but not least, there was highlighted the importance of collaboration across different region, institution, and in the conference I mentioned about this African what we call the vaccine regulatory forum. That is an example of how we can different regulatory authorities can come together to have allow efficient and what a coordinated one regulatory clearance to apply to a number of countries. So I think that I will close here, but really the whole 2 days meeting proceedings is now online. Its recording is online in the WHO webpage. So I'm sure that some of you, if you're a clinician, you may be more interested in terms of the clinical sessions, and if you are developers of vaccine something, you may have some other session that the resources are there in our WHO webpage. All right, I will hand over back to Sanjay, and thank you.
Thank you very much, Dr. Nguyen. That was a nice of the WHO 2-day meeting. So I suppose there are a couple of pertinent questions that we probably need to kind of get to see if we can get you to answer them. So one of the questions that was asked on the chat is, will the ring vaccination strategy apply to all regions? And I suppose the next question is, would it apply to all vaccines? In other words, both the MVA and the LC16?
Yeah, I recall that the ring vaccination, because of the setting, last it was in with the Ebola West Africa time, and later also, and the consideration that is the most effective way to target the limited number of doses to the most at-risk groups. So the design is really for that purpose. But I don't think that the situation would be like in Europe, because we may not, of course, as I say, the clade 1b, we don't know how it will behave, but the likelihood is that in Europe we will now already vaccinate. The national authorities have recommended vaccinate like post-exposure, right? So, but then you need to be a contact. Ring vaccination doesn't mean, because it's not all the contacts. In ring vaccination is beyond contact of contacts and whole village. So this different concept, and I do not see that the rationale for doing, because ring vaccination is for research purpose, meaning to see that whether the vaccine effective in the certain population. But for the control measures is another aspect, meaning that now with our limited doses, whether ring vaccination would be the best way to it's not like a whole, I mean, campaign mode. It's no campaign mode because no vaccine available, but that I think that's a different strategy. And ring vaccination itself, I don't see that is appropriate for, meaning that to stop further transmission that's efficiently.
So I suppose, and there's supplementary to that, in order for us to be able to do that effectively, we need to have diagnostics in place, don't we? And this is going to be the key issue, as Prof. Demby had said so already, that we really need to decentralize diagnostics, get the diagnostics out there so that we can identify cases definitively in order to think about vaccine strategies, yeah?
Yeah, absolutely, and I think that it's go hand in hand. It's not about the vaccination, but how you make difference between suspected and non-suspected cases. You need to test them, right? So you don't have enough diagnostics, so it will impair our intervention, whether it's a vaccination or other. Meaning that to refer to for clinical care, whether this is a really mpox or is either the herpes or other diseases. So diagnosis is the key, not only for vaccination and for our control measures.
And I'm sorry, I'm just going to push this just one little bit again. So in Europe, when we had, the clade 2b epidemic, we kind of used a strategy of vaccinating high-risk groups. And so in our case, this was GB, MSM populations. Do we have enough granular data around clade 1b at least to be able to identify high-risk groups? Because that would be another strategy, wouldn't it?
Definitely, but as I mentioned already, that now beyond DRC, perhaps Burundi or some place where case clade 1b is more like 100 of cases. Of course, in DRC more, but in Europe we have only the first single case of clade 1b, so it's very difficult to now to see that which would be the strategy to address that. And again, is
sorry, I was asking about what is WHO going to do in Africa? Sorry.
What's WHO going to do in Africa? Well, our Professor Niguez already mentioned that we are hand in hand in all these our what we call global strategic preparedness response plan. That's very hand in hand with the African CDC continental response plan, and we are part of the incident management support team or team. We do have our country presence. I think that that's maybe the asset of WHO. We have in all those affected African countries, we do have the country representative office there, as well as people on the ground. And definitely we will mobilize with this joint effort with Africa CDC to provide expertise on ground, and of course all the discussion on global level on the vaccine deployment, meaning that so we are part of that, of course, heavily. So we do support directly Africa continent with our presence.
Okay, thank you very much. Dr. Guer, please stay on, and we'll bring you back into the discussion towards the end, because we can try and have a joined up discussion between Africa CDC and the WHO. I'm going to hand over to Esteban now.
Thanks, Sanjari. After these initial presentations, the epidemiology, and also remarking the value of collaborative efforts, we were expecting to have an important issue that has not been very well known, and this is pregnancy and mpox, mpox in pregnancy. Unfortunately, the speaker, Professor Jean Nechega, has just announced that due to a family emergency, he was unable to be here today. And we are very sure that we will have him in a future webinar. Being pregnancy is so important and so unknown, it's clear that we will have information about this in the next future. So I will go to the next speaker, and also a very important topic and largely awaited in this webinar from the beginning 2 weeks ago is that is the community perspective, and particularly at the local level. And for that, we have Kofi Donkor, and I thank him for being here. Kofi is the director of the LGBT plus Rights Ghana, a community-led advocacy group fighting for the rights of LGBTQ people in Ghana. Kofi will be giving a short presentation on what queer people are experiencing on the ground, the challenges and education for gay men amidst criminalization and mpox in Ghana. So thanks, Kofi, for being here. I hand over to you.
Thank you, Esteban, for having me. Hi, everyone. It's good to have all of you here. I'm trying to present this. I'm going to hit the share. Oh, I think I need to be allowed to share my screen.
I think you're allowed, Kofi. So try hitting the share button. Does anything come up?
Yeah, it says open system preference. Oh, okay, awesome. So sorry. I'm trying to wrap this up.
Don't worry, don't worry, don't worry. No stress.
Hi, I don't know if you have my presentation. If you could even share it from your end, I'll be very happy. I seem to be having a bit of a challenge.
Did you send it, Kofi, to me?
Yes, I did.
Okay, there it is. Okay, good. Okay, so I'm opening it now. Hang on, 2 seconds.
Awesome. Thank you. That's helpful.
Okay, and then go to... Mm, 2 seconds. There we go.
Awesome. Hi, everyone. Thanks once again for having me here. My name is Alex Kofi Donkor, and I am the director for LGBT plus Rights Ghana. And my presentation today is on outbreak in the queer community in Ghana and our responses and the challenges so far. So what I'm going to be tackling on will be mostly on response of LGBT Rights Ghana and key points from our live Instagram conversations, challenges, and then way forward. And next slide.
There we go.
Awesome. So for us as a community, I would say that for most times, informations relating to health takes a little bit of time before it gets to the community. So for 2022, when World Health Organization declared mpox as a global emergency, I would say that for us as a community in Ghana, the information wasn't readily available, and I would say the level of knowledge around mpox was incredibly low. And then we also heard of the outbreak again in 2024, where it was also declared as an emergency again. And then for us, the first mistake of not really putting readily information available for the community also meant that we would need to make sure or do the necessary works from the local level to make sure that information of this nature is given to the community as early as possible. And I think this is also as a result of our experiences when it comes to the HIV epidemic that also, or pandemic that happened. Again, we are also in a country where, for us in Ghana, there is also the criminalization of LGBTQ persons, which also really affects the level at which even LGBT advocate activists and then, health advocate can even disseminate information and all of that. So one critical area where I would say that lots of the challenges really emanate from is the fact that there is also criminalization of LGBTQ persons in Ghana. So also this also really goes further to also limit the level of advocacy and then the level of engagement that we could really present to not just the community, but then also various institutions and stakeholders that are involved in health-related interventions. Next slide. Awesome. So for us as a community to put things into our hands, we decided to make sure that we will give enough information to the community. And one of the areas that we do that is to use social media as a platform to really reach the community. And because the community is a criminalized community in Ghana, a lot of the time we try to use like various means to be as secured as possible, and one of the means that we also use in engaging would be social media. So social media really plays a major role in disseminating information, and so we use Twitter, we use Instagram, we use Facebook, and especially WhatsApp for easy communication. So we had an Instagram live session where we had it in partnership with Impact Global Action, and then also us. And then in the live conversations, what we discussed was what were the basics of mpox, what are the symptoms, what are the preventive measures, what are the strategies, and then what is the level of vaccination, and then also what are we learning from previous emergencies that has also happened in the past. Next slide. And you can find this Instagram live on our social media platform, so it's still there as a saved document. So thank you. So one of the key points that we drew from the Instagram live session was one, it's essential that gay sex or any form of sex or any form of non-heteronormative sexual activities are decriminalized in order to reduce stigma and increase access to healthcare for gay, bisexual, and men who have sex with other men in Ghana. Now, one other thing that we also realized was that there is a need for vaccine politics to stop so that mpox vaccine can reach people in Africa who needs it more. And the reason for also like really drawing this points was the fact that in Europe and in other places, there are already vaccines that are offered for the prevention of mpox. And I think that for us also in Africa, we don't have to necessarily wait for it to hit a global emergency for such actions to be put in place. And then the third point is that governments must be held accountable for their responsibility to ensure that all citizens are safe and have their health needs catered for. Next slide.
Agora não, tô aqui, vou ouvir o tipo.
Jacinta, would you mind switching off your sound, please? Thank you.
Sanjay Bagani. Sanjay.
Okay, so also when the emergency also happened, one of the things that we did as a community was to put out slide or flyers that talks about mpox and what's the basics information that is needed for one to be more careful and safer. And so we spread this across various social media platforms, and especially on our WhatsApp page where information is easily disseminated. Next slide. So these are some of the designs, and it's also on our social media platforms as well. So some of the challenges that we have also realized from disseminating the information and also putting out the campaign around mpox is the fact that our campaign efforts are restricted to online spaces at the moment due to the environment in which we find ourselves. And then there is also fear mongering and misinformation in the media and public domain. So there is already a lot of misinformation around LGBT issues. So once mpox is associated to the LGBT community, then the misinformation and disinformation is likely to really spark a hate towards the community, and therefore there is a need for us to put in place systems and measures where there is an interaction between community and various stakeholders to be able to disseminate information that doesn't stigmatize and also doesn't discriminate against our community and other communities alike. And so there is also lack of coordinated strategy for health, for state health institutions to support efforts by advocates. And so, I mean, the outbreak, in as much as for us as a community, we are more concerned to really put enough information out there. From the state level, we've also not seen any effort at all from any state institution to really help in disseminating information even around mpox, and therefore makes it even difficult for our effort to be met with that of the state's efforts. And then also fighting against stigma, which could also discourage people from testing to seek help. And we've also seen this in other areas of epidemic, pandemic, and we can even use the HIV as an example where stigma really plays a lot of role in seeking health services, and therefore we believe that positioning ourselves in a more coordinated manner will really help us to either reduce the level of stigma that are experienced, especially from the health institutions or healthcare environments. Next slide. Okay, so what is the way forward? I also try to propose some way forward. So some of the way forward that we've identified here is challenging governments, especially in countries where LGBTQ is criminalized, to address health needs of all citizens. The next one is to actively fight against stigma and misinformation. The third is mpox vaccine must be made available in Africa and across all African countries, including places that are more difficult, like the Congo and other places where there are wars and all of that. And then international collaboration with African advocate groups to educate our community on what mpox is and its effectiveness thereof. The last slide. All right, so this is LGBT Rights Ghana's website, and these are our social media platforms. And please feel free to visit us on our platform and engage with us on various questions, topics, or anything you'd want us to also discuss about. So thank you so much, and I will end here.
Thanks, Kofi, for this informative data. There are still gaps and important gaps to fill, and one of the words you mentioned was collaborative efforts and also fighting against the stigma. So we have now time for some questions. If you have any live question, raise your hand, and if not, we will go through questions in the chat. Let's start with one question. Mpox is a disease that is already linked to stigma, or maybe linked to stigma. Is the fact that any person LGBT person may have mpox in Ghana. Is it connected or is it linked to a higher degree of stigma? And if so, do you think that the reason is because of the sexual orientation or because of any other issues?
Thank you so much. So far we haven't heard of any cases in Ghana yet, but we are also using a previous data to also like judge what the possibility would look like, and then we also, when we know that when it comes to those who are mostly affected by also mpox, the LGBT community or the gay and bisexual and men who have sex with men, one of the key community that is deeply affected by this. And so for us, we just want to put this preemptive effort and measures in place so that we are in a more better position to respond to the needs of the community. Now, again, where to also draw the other point of your question is the fact that because there are already criminalizing laws that already exist in places like Ghana and all of that, it makes it difficult for the efforts of the community in trying to put in place health needs and care for the community difficult. And we believe that in as much as the mpox virus hasn't hit Ghana, the possibility that if it does, and then the history of the fact that the MSM community is highly target for this would also mean that we need to position ourselves. But then laws that really criminalize us, therefore, makes it difficult for us to be more pragmatic in our approach, and therefore, our reason for being more careful in this regard. Yeah.
Yeah, I see. We have heard about collaborative efforts in the presentations before yours from WHO and also from Africa CDC. You have those speakers here. So, Kofi, what will you ask them or their organizations to provide support in the fight against stigma, and also in providing collaborative efforts into education too?
Absolutely. Thank you so much. Yes, so my advice would be that there are already networks, and there are also growing network within the MSM, GBMSM, and LGBT community that are really putting in place efforts to make sure that the community we serve are more protected, and therefore there is a need to engage these networks and this group, and there is a need for us to be on the table to have a more meaningful and more fruitful conversation, one that is devoid of stigma, or one that would prevent stigma. Yeah.
Yeah. Thanks, Sanjay.
Yes, thank you, Esteban, and thank you, Kofi, for an amazing presentation. That was really fantastic. So Alex, when he asked the first question, brought up two key populations, the MSM population and people living with HIV. But we've also heard a little bit earlier today that, you know, when we started to see 1B kind of emerging in Eastern DRC, there was another key population, which was sex workers, and many of these are female sex workers. So how do we kind of try and start to get these community groups together, because it is the same fight, and quite rightly so, these are highly stigmatized groups all the way along, and so we really need to think about how we try and bring them together.
Absolutely, I do agree with you on your point, and I think that would be the way forward for us. And I think these, I think there is enough effort, and there is enough organizers from these different communities. And I think that being on the table and being a community that also supports the work of Africa CDC and every other group would be incredibly amazing. I think we are very much ready and prepared for that effort. Yeah.
Thank you very much, Kofi. So shall we bring back Dr. Goued and Professor Demby into the conversation, and we see if anybody has questions. We can now start to have a more general discussions if people want to. Prof. Demby, are you still on the call with us? And if so, is your camera going to be able to be on? Anybody see Prof. Demby on the call?
Oh, I cannot see him. No.
You think he might have dropped off?
Yeah, probably.
Okay. Okay. Are there any? So there's a lot of questions in the chat, and a lot of them would probably have been directed to Prof. Demby and Africa CDC. But you know, as he'd said before he left, they have an open invitation. And so we will make sure that for all the next ones, we will have representation from Africa CDC so that, you know, we can get them to answer questions and perhaps have some more discussions, discuss data as and when they get it. So what I'm probably now going to do is hand back over to Taimur, because it sounds like we may be able to bring this to a close a little bit earlier today. So Taimur, are you around?
Thank you so much, Sanjay and Esteban. So, as you know, there were two speakers that we didn't get to hear from today. The first one was the mpox in pregnancy, and then the second one was on the case fatality ratio for the different clades. Both of those new publications that just came out in the past couple of days. So the last one on the different clades, that presentation I will share with you now. Also the link to the paper itself. The mpox in pregnancy, we will invite Professor Nashega back to the next webinar, which will be in 2 weeks' time. And we have some other really interesting speakers already lined up for that webinar. So I think we will not labor this. We will end this call now. As we've said before, if you do have suggestions for topics, or please do reach out to us, and we will try and accommodate that into the program. So with that, we will send the link to the recording along with the slides that have been presented today, along with the one on the case fatality ratio tomorrow morning once everything is pulled together. And I will be sending out a new invitation for the same time in 2 weeks' time for the next webinar. So with that, again, on behalf of EACS and ECDC, I want to say thank you so much for your attention and hope to see you in 2 weeks' time. Bye, everyone.
Thanks to the speakers and to you all. Thanks.